Hello, everybody, and welcome back to another episode of Hybrid Healing Hour. Today, we are going to be talking about lymphedema. We have two very special guests with us. It's Christy Teisen and Theresa Feblis. Why don't you go ahead and introduce yourselves and tell everybody your background and how you got started with this?
Sure. So my name is Christy. I'm a nurse with Certified Homecare of the Palm Beaches. And basically, we provide home health. So we come to your home and provide rehabilitation type services like physical therapy, occupational therapy, speech therapy, as well as skilled nursing. And our specialty area is lymphedema and wound care. And basically, this is our director of lymphedema therapy, Theresa, right on my left here.
Hello.
And I never met anybody that knows lymphedema as well as this chick. And she is a lymphedema guru.
When we met her in our office, I have to chime in. I fell in love with her immediately. She was just so knowledgeable, and I was like, we have to have her on our show. So I'm so glad both of you are here. But go ahead and tell us how you got involved and what got you started.
Well, my name is Theresa Feblis. I'm a physical therapist assistant, and I specialize in lymphedema therapy. I've been doing it for probably about close to 28 years now. And I guess you can say I got into it way back years ago. I was at a hospital outpatient clinic. There was a therapist that went to a continuing ed that specialized in lymphedema because we all have to keep our, license up, CEUs, et cetera. And she introduced me to the course she was very interested in, and it was lymphedema treatments. And she showed me how it worked, the outcome of it, the patient's satisfactions, and I went and got certified in it, and I've been practicing ever since. So pretty much that's it.
Wonderful.
So, very few people know what lymphedema actually is. In fact, even plenty of practitioners get confused with the differences between edema and lymphedema and different types of swelling. So why don't we first talk about the lymphatic system and what it is?
Okay. Well, first, the lymphatic system is used for balancing of fluids and helping to fight off infections. And when you are a lymphedema therapist, the whole point of us is to actually reduce extremities because there's an accumulation of fluid that shouldn't be there in the first place because the lymphatic system is not working proper. In regards to the difference, lymphatic fluid is protein-rich. And edema is like edematous water retention, because a lot of patients will start off with seeing a physician with like a swollen extremity, and the doctor will try diuretics first. And after a while, if diuretics don't work or they up the milligrams of the diuretics and the patient's extremity doesn't reduce further, what often remains is the protein portion, and that's what lymphatic fluid is composed of, water and proteins. And how it travels in the body is literally like through like a pumping mechanism, kind of like when the blood pumps through. And for some reason, the pumping mechanism to get the fluid out is not working to the fullest potential. So what happens is we as therapists go in and recreate the pump by doing the manual lymph drainage and wrappings to reduce the extremity. So a lot of times physicians will try water pills first. That's how we get them. After a while, the water pills don't work. So the next step would be to try to diagnose them to see if they have lymphedema, and then we treat them lymphatic-wise with the massage and the wrappings is what we do. So
it sounds like, as a clinician, I will say it is hard to see, to tell if somebody has just edema or lymphedema. So I know typically, yes, it is a trial and error. And so I want patients to understand it's not something we can necessarily just look at it and get it right on the first try, per se.
I would like to mention that normally with diuretics, the healthcare providers, physicians, and PAs and nurse practitioners will give the diuretics 90 days to work. And then after 90 days, if the diuretic is not decreasing the extremity, that's when the lymphedema protocol can come into play. And that's when Theresa will do her manual massage, lymphatic massage. You know, everybody loves to hear that word massage. Mm-hmm. Yeah, so she does do a massage, and then it's followed by pressure gradient dressings. And Theresa's very careful, too, not to overload the system. So a lot of times we'll have skilled nursing in there along with the lymphedema therapist, just to make sure the cardiopulmonary status is being monitored and that they are excreting this fluid and not retaining it, because the last thing we want to do is put somebody in the hospital.
Right. You don't want to just shift the fluid to a different place.
Exactly.
Right. To give fluid overload or heart failure or anything like that.
Right. You do it in sections is what you do. You don't, you want a therapist that knows what they're doing, because some individuals that might not know as much or have seen as many patients, you never want to aggressively wrap somebody, because a lot of times you get them, their bilateral legs swollen, or even just an extremity. You don't just wrap as hard as you can to the groin. You do it in sections. We do like baby below the knee, one side, depending on the individual. We look at their sedentary lifestyle, if they're overweight. We look at their background, if they have cardiac issues, pulmonary issues. You want to reroute the fluid gradually. You don't want to aggressively do it, because you can send them into congestive heart failure or other pulmonary problems, and we're trying to avoid that and do it as safe as possible for that individual. So,
in our practice, we really try to limit the use of medications as much as possible. And a lot of people don't understand diuretics are not without their problems. Plenty of times we see worsening of kidney function when you start someone on a diuretic. So if you can do a non-pharmaceutical treatment first, I think that's the route to go, right?
It's a safe way. I agree, because oral medications don't always work, or a lot of times they're tried first and you have to have an avenue afterwards. You can't just say, okay, we tried everything. The next step usually is the hands-on manual lymph drainage and the compression wrappings to help. The treatment works 100%. When I have a patient I work with, they meet their goals every single time. Compliance is an issue. We always have to make sure that they comply and work with me, because I push that and I educate them. But
Can you explain what the compliance part is?
Well, that's leaving the bandages on until maybe my next treatment, not take them off 2 days before, because the body produces lymphatic fluid 24/7. It just doesn't make it one day and then stop and then come back. You have to leave compression on until my next visit is what it is. So,
and I do want to get into more detail with that when we get to the treatment topic, but part of our practice is always getting down to the root cause, and that's how we typically try to avoid the medications. And so what are some of the causes of lymphedema?
Well, there's multiple. Cellulitis.
Wounds can cause lymphedema. Cancer can cause. There's two forms of lymphedema. One's primary, you're born with it. The other one is secondary. And usually I would say the majority of our patients we treat are with secondary lymphedema. They have a diagnosis of, I'll just say congestive heart failure or pulmonary hypertension. They could have had a hip surgery, a knee surgery, and age is an issue. Weight is an issue. We look at all of it. And what happens is, for some reason, whatever that primary diagnosis is, it compromises the lymph system, the strength to help pump the fluid out so you can eliminate it. So the whole point of us when we go in to do the treatments, when we do the massage and the wrappings we're recreating the pump that's not quite working, that has been compromised maybe from that primary diagnosis or secondary diagnosis. And our job is to help them eliminate it. It helps prevent infections. It helps prevent wounds. Wounds do cause infections. So a lot of times when I see patients, they have these lymph blisters, these blisters that are full of fluid. Patients have thin skin. And what happens is, as the fluid stagnates in the leg and builds, they have a tendency of developing cellulitis, which is like an inflammation of the tissue. And 100% of the time when we reroute the fluid and get the extremity down to a normal size, their chances of infection decrease tremendously. They don't need to always worry about it. Take an antibiotic, let's fix it. But you have to, I always say, step out of the box of practice and look at what's causing the infection. And a lot of times the swelling that's been there a while in the leg is the true factor. Those accumulation of proteins cause the infection, and our job is to help them eliminate it, because it's not pumping out the way it's supposed to, and then get them into, like you were going to talk about, a garment to help maintain it, because unfortunately it's a chronic disease. It's not acute.
Right.
So
We were talking earlier amongst ourselves that worldwide the number one cause of lymphedema is actually a parasite, filariasis, that's transmitted by mosquitoes. And that's in the rest of the world. In the United States, we don't see that. So we have other causes of lymphedema. Absolutely.
We're here in Florida, I see more, I hate to use the word, the geriatric state, the lymphedema in the older population, because they have a lot of more underlying comorbidities, more problems, and that seems to compromise the lymphatic system in making it work. And our job is to go in there and help them so they can live a functional life and not have to worry about wounds and infections and stuff. So
now, is it any different? We mentioned how cancer can cause lymphedema, right? Because that is technically it's a very big infection. I would look at it like that.
Absolutely.
But what about status post-cancer, like on women who had mastectomies, but it's not the mastectomy necessarily that causes the lymphedema, right? It's when they have to have lymph node removal. So I know there's procedures out there that some oncologists are performing where they can try to save the lymph nodes now, but do you see a lot of people, and what is the sleeve that they have to wear and the precautions they need to take?
Well, first of all, the cancer is the primary diagnosis, and when they have a diagnosis of cancer, they develop secondary lymphedema, that being the primary problem. And usually some form of chemoradiation is used. And when you have your lymphatic system that's been, I guess I can call it tampered with, whether it be with chemo or radiation, some of those lymph nodes and those pathways, sometimes they remove the lymph nodes, have been damaged. So the flow of the fluid is not able to reroute and be eliminated the way it's supposed to. There's scar tissue that develops. So our job as therapists is to go in and to help reroute the fluid around the area that's damaged. But the cancer, like I say, is a primary diagnosis. I would say the majority of the patients we see are secondary lymphedema because they usually have underlying problems, like I say, cardiac, pulmonary surgeries, hip surgeries, knee surgeries, and usually if they're a little bit overweight or the sedentary lifestyle, they develop the lymphedema in their later years, I should say. So in the beginning when I was trained, I worked with some pediatrics that had lymphedema, but they were born with it, and that was the primary diagnosis. But you can develop lymphedema from cancer. But it's on a secondary basis. And most of the patients I will admit that I do see are ones with wounds or cardiac problems or pulmonary problems. And I wish I work with doctors, and I would love to have the opportunities with many of the surgeons that do mastectomies, that I would love to meet with those patients and actually educate them a little bit better on what lymphedema is, how it can come about. Like some women that might have node removal in the axillary, they might lift something too heavy. That is compromising the lymph system more and actually can cause the extremity to swell. So I love education, because if you can educate a patient to help prevent developing lymphedema, that would be fantastic, because then later I don't have to treat them. They can be more aware of it or nip it in the bud before it gets to the point maybe where they have to wear a garment. Maybe I can just teach them massage or something to help reroute the fluid. So
yeah, that's exactly what I would like. That's what we're about, once again, is prevention, right? And something so small like that, if you can just avoid lifting something so heavy, that's great.
Yeah.
Many times in our practice, we see patients who come in with wounds on their legs that aren't healing and don't heal for the longest time because the circulation is poor anyway, especially in the shin area. And a lot of people don't realize that you have to treat the underlying lymphedema for the wound to heal, because you're just not getting blood flow.
100%. There's wound care centers that I do receive, and physicians. I receive patients that the patients are like, they've had the wounds for a long time, but the extremity stays swollen and the wound is actually draining, because fluid travels to least resistance. It will come from the wound site. So a lot of patients are like, why is this draining so much? It's actually lymphatic fluid, I'm sure blood too. And what happens is you want to make sure that you can reroute that fluid. Lymphatic fluid is superficial. It's like right below the skin. Blood carries oxygen cells. Oxygen cells promote tissue growth, and that's what we're trying to do so a wound will heal. So when a patient has a chronic wound And I've had them where they've had them for like a year, 8 months, 6 months, but they still have the swollen extremity. They don't look out of the box of the wound. The actual swelling of the leg could be actually causing the wound not to heal. So I will say it too, 100% that I've ever had patients in my years when they've had wound care, when we have a nurse go in through our company and they do certified home care, they do wound care first. And after that, I go in and do the manual lymph drainage to reroute the fluid. The extremity is still swollen. And then I wrap them with a short stretch bandage. And when you get rid of that lymphatic fluid, that accumulation of fluid that's stagnant in the leg, blood flow gets to it every single time, increased wise. It flows to it better. It has access to it. The wounds heal in half the time. They do every time. And the patients are so happy because they're like, oh, I could have had this wound healed a long time ago, and it's not, talking about anyone. It's just trying to help them heal it and get the patient. My goal is being a therapist, getting them back functional, get them back walking, exercising, not live a life to doctor's appointments all the time dealing with a wound. I mean, that's what I'm trying to avoid too.
Absolutely. And so you've touched on treatments, you've touched on wraps, you've said all of these things, but let's put it all together now for our audience. Tell me about the treatment. And Christy, you were telling me it's actually called complete decompression, or I'm sorry, correct me on this.
Complete decongestive therapy.
That's it. Complete decongestive therapy.
Yeah.
So tell us, what's that entail?
Well, okay.
You go for it. You're the guru.
No.
I'm here to support you, rock star.
Okay. No. What happens is when we get a patient, a lot of them ask, how do I start the treatment? How do we get involved with it? First of all, like I said, we get prescriptions from doctors so that it's covered under their insurances, Medicare. And what happens is they're initially evaluated from a physical therapist. Goals are set. And then after that, treatments begin after the evaluation. And during the treatments, we actually start educating them in the beginning about what we're going to do, how it's going to work, and what our goals are to achieve to get them back functional and get the wound healed or the extremities smaller. So we start off with the manual lymph drainage. We help reroute the fluid. It's not pumping out the way it's supposed to. And once we reroute the fluid and we do a massage, then afterwards, we wrap them with short stretch bandages that only give 50% pressure. It's not like a long strap ACE wrap. ACE wrap is long stretch, which means it can actually, I want to say tourniquet it, because a lot of people are like, just squeeze it harder, let's try to push the fluid out. When we do the treatment, everyone just thinks it's wrapping with a bandage. It's not. It's with a short stretch bandage made for lymphedema. You start distal at the toes. You never not involve the toes because fluid will always travel to least resistance. So I always do wrap the toes because I'm always trying to reroute to, we call this a sternocleidomastoid duct. It's an area where the fluid goes to be broken down and eliminated by urination is how they do it. But my job is to wrap them gradient, tighter at the foot, and then we go looser upwards towards to the groin area, to the inguinal lymph nodes is what we call it, the groin lymph nodes. We're always trying to reroute. You can't just go in and squeeze because it will shoot to least resistance. I'm trying to get them to reroute it and eliminate it so we get the extremity down to a normal size. The treatment itself, you will always achieve your goal to a normal size. And then the key after we've done a few weeks of wrappings, because my job is to measure every week. I see the decrease in number. And after a while, if their numbers don't decrease when I measure, they kind of plateaued. I've been doing it for a while enough, I can tell by look. And eventually, what we do is work on trying to get them a compression garment to maintain that decreased girth, because a lot of individuals are told by other medical people, well, you have swelling, go get a garment. Garments do not reduce. Stockings do not reduce an extremity. They are for maintenance. That's why you have a therapist come in who's certified in lymphedema, like me, and then what would happen is you get the extremity through treatment down to normal. And after normal, then we fit you with a garment to maintain that normal. You don't get fitted when the leg's swollen because all it'll do is maintain that leg that's swollen. And you want a healthy leg, wound-free, no issues with it. And once we've gotten a garment for them to help maintain, my job is to educate them how to put it on and off, because I know that's a big issue with our population. I have assistive devices I leave in the patient's homes. We teach them how to put them on and off, hoping they can make them more independent.
Especially if they have like arthritis.
Yes, bad
and whatnot.
backs.
Yeah.
And poor manual dexterity. You got to take that into consideration as to what kind of
Garment that's
maintenance
used.
device.
Yeah.
Yeah, because
Barrel
everybody's
wrap
like,
or compression.
yeah, because a lot of patients are like, oh, I already tried stockings. They don't work. Well, there's other garments. There's ones called Ferro Wraps, which are a Velcro, which is like Velcroing a shoe. And that can be done, worn by a patient very easily and works perfectly fine, totally functional. And after we've gotten them under maintenance and they're maintaining, I give them a few visits to make sure that they got everything under control. Then we do an exercise program, because it's important that they have some form of exercise to contract muscles, which promotes the fluid also.
Exactly. So tell us a little bit about the exercise program. Like, what do you do? Is it geared towards that patient and what they can handle? Or are you putting them all on a treadmill and making them run 5 miles, right?
Yeah, I wish no. What you do is, that's why when we do treat them in the home, and then what happens is, because we come to them, so what happens is for the home exercise program, I look at the individual, I kind of assess, I look at how they walk around, I see how they move, their transfers, their ADLs in the house, and what I do is work with them safely-wise, because I need to make sure that they're balanced, they don't, like if they're off balance a little bit, I'm not going to give them all standing exercises, not holding on to something. I'm just giving an example. And the point of it is, I look at them as an individual, and you work with them on major muscle groups. I also try to get them to ambulate more, because ambulation works every muscle in the body.
Get up and move, right?
Yes, not just sit in one spot and do a couple exercises. I don't mind that, but the key is, if they're ambulatory, my goal is to get them more ambulatory.
I think people don't understand it's so important to just be able to go from sitting to standing many, many times a day. I mean, that's almost essentially a squat.
Yeah.
And people don't realize, unless you're going to just plop down into a chair. But I work with my patients all the time. Just let's move. Let's practice moving.
Yeah. Even if they're just standing at their chair, if they have an assistive device, I just promote even marching. Stand up, sit, march. You're watching TV, which we do often. So I was like, just spend a few minutes, marching if you're, not wanting to walk around as much, but you have the chair behind you at all times if you need to sit for some reason too.
I say to do it during commercial breaks.
Yes.
Do it for the entire length of the commercial break, and then you can sit down and enjoy your show. The next commercial, get up and do it again.
Yeah, absolutely. So the key, like I say, is exercise too. Even though, lymphedema treatments, the treatment works every time. We'll get them down. The hardest part, I think, for most of our patients, and I'll admit it, is compliance. I'm trying to make them compliant to wear the garments, make them more functional, exercise more, so maybe they don't have to do this anymore and they can live their life to the fullest, when we're at a certain age and stuff. So there's more important things. We have enough doctors' appointments they got to go to, I'm sure, anyway. So
we hear plenty of excuses from our patients as to why they won't wear the compression garments.
Yeah.
And so what do you tell them? How long do you tell them to wear them?
Okay. Well, it is a chronic condition, so they do have to wear the garments, I will say, for the rest of their lives, because there's no cure for it. But for how long, I will say for the rest of your life. But some of them are very adamant. I'm not going to swell. It's not going to come back. I'm good. I'm cured. So before I let them go under my care, I will turn around and I say, okay, you tried the garment. It was working, and you feel that you're not going to swell, I'll give them a few days with no garment, and I will take measurements the day they start that, and maybe 3 days later, I'll compare measurements. They can see that the girth is increased. And I'm like, it's not going to stop there. It's going to keep going, because your body makes the fluid 24/7. So they see it. I'm a visual person, and I like the patients to see what works and what doesn't, because I'm trying to make them, like I say, independent, so you don't have to come back to the treatments, because, the treatments are hard, with the bulkiness of the bandages, but they still are functional with them. It's just, it gets a nuisance after a while, so.
And as far as during the day, do you tell them to wear their stockings the entire day while they're awake and then take them off when they go to sleep?
Okay, the rule of thumb for compression garments are, for when I'm educating a patient, is you put it on first thing in the morning. You're supposed to do it before you leave your bedroom, do your toiletries, etc. Don't go have coffee, read the paper 2-3 hours with the legs in the dependent position, and then go back to your room and then try to put stockings on. Because remember, compression garments don't reduce, they maintain. So the key is put it on first thing. and then go about your day. And then usually about 15, 20 minutes before bed, I have the patient remove the garments. You can't do partial because gravity-assisted activities during the day, gravity's your enemy too. You already have a hard time pumping the fluid up and out. So the stockings are there to do that for you, and you should be wearing them always during the day. Now, I do, as a therapist, need to rule out whether they swell at night. So a lot of my patients will start with the stockings morning to bedtime, nothing at night. I'll take the measurements that day. I'll give them a couple days follow up again for my next, appointment. And if the girth is increased, the only thing it's missing is the night compression, because under treatment, you're wrapped day and night until your next visit. And when you get your garment for maintenance, it's only worn during the day. So, I let them see what works and doesn't. So it's key. And I try to rule out whether they need night compression and at night, to keep it down. So when they wake up in the morning, their leg is still thin and the garments fit, because that's the number one thing. I already tried stockings. They don't work. They hurt me. Well, they're either too low in compression, and they're not, somebody would just say, go get compression stockings. A lot of individuals are like, oh, they're easier to put on. But that doesn't mean it's the right compression because it says it's a compression stocking. So as a therapist that's qualified, you should be able to look at them. I go by body mass. I look at the severity of their lymphedema, and then I determine what type of millimeters of compression needed. That means when they sew the garment together, that's how much pressure is applied to help reroute the fluid. So yes, during the day, I will always say that, because gravity-assisted activities, and if you exercise, you absolutely wear them with it, because that helps promote the flow and contraction of muscles. It's a good thing is what it is. So,
Theresa, what is your opinion of Una boots?
Okay. Well,
I'm interested too. I don't even know what an Una boot is.
Well, a lot of my patients, and I'm just going back on experience, say, I've already tried compression, but they haven't tried lymphedema therapy, which is the short stretch bandages, and padding is what we use. And we reroute it gradient, tighter to looser. Una boots, I will say some people say they have, and I'm not talking bad about anyone, they say they have a lymphedema program. I love my nurses, but they go in and they do an Una boot, which is like a co-band and a like a cotton layer underneath. And what it is from the top of the foot and slightly below the knee, the compression is not the same. It's even. It's not gradient. It's a thin layer. It's latex. And by the way, all our bandages we use are latex free. So a lot of skin integrity and issues. We always make sure that we have a good, source of a bandage. Yeah. And the Una boot is not strong enough. It's a single layer. It doesn't reroute the fluid the way it's supposed to, because it's an even compression straight up. Because like I told you, the key is tighter from the distal end by the foot, and then you reroute upwards to reroute the fluid out. And Una boots, they don't work. Now, if you're like, I'm going to be very, very, very thin with like maybe a little bit of fluid, it can apply enough compression, maybe help. But I don't see.
Otherwise, it just doesn't sound like it does justice.
No, and Una boots are not allowed to go above the knee. They stay below the knee. And my job as a therapist is I have to reroute the fluid entirely. I don't just wrap below the knee and move it to the next section of the leg, the knee and thigh. I have to do the massage in that area, and you have to wrap sometimes to the groin to help them eliminate the fluid. Some patients don't need that, but some do. I'm not just going to move it to the next section and then just leave it, because otherwise they'll have a thin bottom and then it'll kind of look like a popsicle,
right,
like wide up top, and you don't want that. So Una boots are good for wounds and some basic like low compression, I guess you can say, but low swelling a little bit. But when you have true lymphedema, it does not work for it. It does not. That's how I get my patients too. They've tried Una boots. They've tried the wound care centers where they've used it, and it doesn't cut the mustard.
If someone has an active infection like cellulitis or an open wound, can you still do the therapy, or do you wait till it's healed?
When I get patients with infections, cellulitis or a wound that's infected, usually they're on antibiotics for 72 hours. Once they've been on antibiotics for 72 hours, then we can go in and do the manual lymph drainage and the massage and the wrappings. Some physicians wait a little bit longer, but the key is what's causing that infection, that swelling is, because that accumulation of the protein, the lymphatic proteins, a lot of times builds up in there, and that person could have actually just scratched themselves or bumped up to something, and it kind of festers and causes cellulitis to occur. So with the infections, A lot of times, like I say, 72 hours, but it's also my job as a therapist. I have to help identify if a person has an infection. I might get somebody, their legs are swollen, I'm treating them normal, and then all of a sudden they get a warm or a hot leg, or they have pain. Well, we either have to send them to the doctor or have them call just to make sure they don't have a clot. Sometimes we do receive our patients right away. They do ultrasounds first to rule out a clot, but we always are keeping an eye. And that's why you want somebody, I would say, trained in the medical field to make sure that they don't have an infection or a clot. So that's our job to refer it to the physician in case they might need to start an antibiotic.
Well, that's why we like working with a trusted company that has our number, will call us directly if they see anything. I love having like another set of eyes on our patients. You know, that's the way I look at it. And you guys are really good at getting updates, you know, if needed.
Right. We do pictures, of course, with permission. And I love the before and afters for you guys. Any doctors, because the feedback is awesome, and it you know, everyone looks good and everyone's doing their job and stuff or whatever. So it's vital, like you say, communication. I communicate with the physicians all the time, and like I say, it's vital for the patient for their health, because I don't want anything to happen where they have to end up in the hospital with IV antibiotics. So let's nip it in the bud early, and maybe they can just tolerate it with just oral antibiotics. So like I said, that's our job as having nursing and somebody qualified for therapy in there for lymphedema that can help identify that and treat the patient, keep them healthy and at home. So
absolutely. Were you going to chime in?
I was going to say, so I've been with Certified Homecare of the Palm Beaches for probably 10 years or so. And the reason for that is because there's no drama and everybody like means what they say, says what they mean. Our employees are phenomenal. Like Theresa and the nurses, we have amazing results, and they really care about the patients and the outcomes and identifying whether or not it's an infection, like Theresa was going over, like what cellulitis manifests as, like that warmness, right? Like when you're at the leg, if it's swollen and you're feeling warmth, and investigating further and communicating with you healthcare providers and saying, hey, this is what's going on. Do you want to call in an antibiotic? Like we get on it. I wanted to ask you, Theresa, with DVT, with clot, what do you normally see in a patient that makes you suspect that there's a clot going on?
Usually pain. Redness and pain is what is all of a sudden. Like if I'm treating them and all of a sudden they have an excruciating pain or redness, warmth, it also can identify as an infection. But that's why I speak to the physician, and a lot of times, sometimes they might do an ultrasound if one hasn't been done. I mean, that's their job to ours to help identify any indication of an unexplained swelling when I'm reducing, or if it's an unexplained warmth or redness while I'm reducing, because that should all decrease when I'm working with them. We always look at both, clot or an infection. Those are usually one of the ones that it is. Most of the time it's an infection, but a lot of our patients we receive have had an ultrasound prior to treatment.
Just to rule that out to begin with.
Yeah, because of an unexplained swelling. So that's very common. One thing I'll click on for her, she was mentioned about the company. One thing that makes us specialize in this too, and our staff, which is really good, is our staff, we do not subcontract out. All of them work for us. We know who is going out to see the patients, and they all have probably 15 years. I've been doing it, like I say, with this company, I've been over 20 years with them. But all our nurses, OTs, PTs, LPNs, RNs, work for us. We don't subcontract out and call a company, hey, you got somebody that can do this and this. The reflection of us, the physician, it's vital too. You want to make sure you're sending someone in that knows what they're doing, because it reflects all of us. So we want to make sure that they're on top of their game, I should say. So
absolutely. Now, my biggest thing is when I hear from my patients, the downtime. They feel like when they have the wraps on their legs, they have to wait. You come back in every 2 or 3 days to remove the wraps, and then you replace them. They feel like they are trapped at home and they cannot go anywhere. So please let our patients know what do you advise on this?
Okay, well, I hear that often sometimes, but as being a therapist, my job is to make them functional. So when I do wrap them, I do make sure their shoes fit them when they leave so they can go to doctor's appointments, ambulate at home, walk outside if they're able to. Downtime, I don't want to call it downtime. I always talk to the patient. I was like, look, you've had this problem for a while. I'm here for probably about a month, maybe less. And that doesn't mean you'll be wrapped that entire month because maintenance is towards the end too. So our goal is to get you done safely, reduce, and get you functional. So I'm not gonna, how can I say, make them homebound in a sense where when I say homebound, I just mean non-functional in the home. I want them to move. It's only temporary. I always say bite the bullet while you can now, because it'll be good for you in the end, because then you can, we all have other issues. You'll deal with life better. You will enjoy life better because
You'll have
I'll
a
get it
better
done.
quality of life.
Yes,
I mean, in general, right?
Yes.
You'll be able to go and go for walks more, go
Absolutely.
out to lunch with your friends.
Isn't one of the
Absolutely.
complaints too, when people have swelling in their extremities, it's painful.
Exactly.
It's heavy. They have decreased range of motion.
Hot.
Hot, yes. They have neuropathic issues. The accumulation of fluid in an extremity when you have neuropathy decreases the sensation even more. Pain sometimes is increased, but when you actually reduce the extremity, increase blood flow with that promotion of the compression with a stocking or under treatment, decreases all that. And there's no cure for it, but it will make things better for a patient. And that's our goal. And you said it, magic word, quality of life. That's the key. That's the key. So there's no true downtime. There's none, because I'm temporary to make them so I don't have to come back, and that's my goal, so they can make them, a better quality of life.
I'm glad to hear you say that.
Yeah.
So, like you said, this is a chronic condition. You can have flare-ups. Is there what are your top 3 triggers for flare-ups that you see?
My number one is non-compliance.
I was just going to say.
Exactly. Like when people don't wear the wraps like they're supposed to, when they don't do the stretching or the exercising that they're supposed to, right?
Absolutely.
Okay.
And then we ask you guys to write another prescription
Yep.
for certified
order.
home care with Palm Beaches, lymphedema.
Yeah, I call them frequent flyers. I hate to say that, but that's what they're called, because a lot of times they'll do really well for a while. I've educated them how to maintain. That's the key, because it's a chronic condition. And with the tests that we've gone through to make sure that it's maintaining well, they'll see that it works. I'm not going to lie, we're all human, and being here in Florida, it gets hot, and some of them are like, I'm not going to do this during the summer. Well, they do it as long as they can. And then what happens is I educate them upon treatments, signs and symptoms to look at, that would be a trigger of the beginning of the lymphatic issue getting worse. I don't want to see you at the worst stage.
Right. You want to see when it starts to come back so you can get it.
Yeah, nip it in the bud. That's what you said. If you do that, you're on treatment shorter amount of time, and then it's kind of like a diet. You cheat it a little, but then you can get back on it, and then you're good for a while. I mean, we're all human, like I say. It's a chronic condition, so the key is like I say, is for maintenance for them, and it's hard until there's that magic thing. That's why a lot of patients are like, they try the diuretics, it didn't work. It's not always straight edematous water retention. The lymphatic issue, that's how we get our patients. They have lymph issues where the protein is accumulating late. It's just not pumping out the way it's supposed to because those underlying diagnoses. So there is a treatment for it. And a lot of times it's overlooked sometimes. And they don't want to keep taking an increase of diuretics because they can't leave the house because of,
And then you have to go to the bathroom all the time.
Right. So again, as a therapist, we want them functional, moving around.
So do you have any case studies that you could show us or tell us about?
Yes, I have some that were some of my worst cases, and I do have permission to show befores and afters.
So for our audience, we also have a YouTube channel that she's going to show some pictures. You're welcome to go on and see what she's talking about.
And these are some of my severe cases. And these ladies and gentlemen, how can I say, cheated a little and came back, and now they know that they have to do it all the time, and they're doing fantastic. So I do check up on
So
the
they
patients.
learn from their mistakes. That's awesome.
Yes. So here's a before of an individual that I saw, and here's the after.
Oh, wow. That's significant.
Right. Now, she does have swelling in the knee and thigh. I'm not going to lie. Some of my patients do not have the physical capability to put a thigh high on. So I have to look at the patient. That's why I say you have to evaluate each case individually. I'd rather them take care of something versus nothing. So she opted out to do below the knee compression. And she's like, and I taught her actually how to wrap her knee and thigh to help maintain it under control instead of ignoring it, but she's able to do the stockings is what it is. So I have one more gentleman here. This is a before.
You can see his sock lines in his ankles. Like they
Yep, that pitting. That pitting is really bad is what it is.
Even his toes.
The darkening of the skin.
You got it. A lot of times vascular is an issue too. We do have patients that are referred to vascular surgeons. They do ablations, and they still find that the swelling is still there. And in the long run, the lymphatic is not curable or surgically fixable. They try to help with circulation with the ablations, and it might help them a little bit where maybe they don't have to wear night compression, but still, unfortunately, they might have to wear compression during the day. And here's the after of that gentleman. This is my little guy. He's really good. He's a walker too. And he was so happy he was able to fit in his shoes, socks, and he was able to get up and move around in the house because his legs were lighter and he had better range of motion. So that worked out really well for them. I have others, but that's good.
No, that's great. So Christy, why don't you go ahead and tell our audience how they can reach you both?
Sure. So Certified Home Care of the Palm Beaches. Our number is 561-368-8744. And we are developing a website right now. We're upgrading our website. So
we'll put that in the show notes.
Yes, that will be in the show notes. Okay. And Medicare does reimburse us for our services. So if you do have straight Medicare, our services are 100% covered, which is great. But we do also have a private pay option. Theresa tells me sometimes we do get patients like from Canada and whatnot. So
we do privately, yeah.
Well, we have a lot of snowbirds down here, so that's perfect that you have that as an option.
I do work with the VA also. I've been working with them for probably about, 10, 12 years. So if you're a veteran and you go to your once a year follow-up, I work with them and get the prescriptions necessary. I order the garments for them and I have them shipped to the house, so it's all covered for them as long as they keep up with where they're supposed to with the VA. And of this year, a lot of patients can't afford compression garments, but this year of January 1st, Congress just approved funds to pay for compression garments. It's a little tedious. We have to, go through the notes to be sent in, the prescriptions that are necessary. And I work with the physicians to get that, and I arrange it with a company. And what happens is that company, I give them all the information. I send the patient there to be fitted, or I can call in measurements in case they have a hard time with transportation. And the garments are sent to their house, and then they have it. So it's kind of nice, because a lot of times I've had patients that financially can't afford a garment, and I've had to walk away,
And that's unfortunate. So. Then they can't do the compliance, even if they really wanted to. So, wow, that's amazing.
Yeah, one thing I want to point out too, a lot of times patients are referred to us also, they say they have a compression pump. And I just want to make sure that they're aware compression pumps are used like twice a day for 55 minutes, I would say. But your body produces this fluid 24/7. And again, we're trying to make you functional. Pumps are used in conjunction with garments to help maintain the girth. It doesn't just squeeze it out and do good for the whole day. You have to continue to wear the compression to help push the fluid out. I'm not against it. It's just work together. You want both is what it's for.
I'm glad to hear you say that. We have a few patients who have those pumps at home, and it's hard enough getting them to use those too.
Yeah, and then they're like, oh, it doesn't work, da-da-da. Well, it's just the education of them to help them. Like I told you, the maintenance. The maintenance is the key when it comes to it, so.
Thank you, guys. This has been so informative.
It really has. Thank you for coming on. It was wonderful
having you on.
Thank you very much.
Thank you for having us.
Yep, thank you.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.